Wonderful. I'll hand it right over to you, actually.
Perfect. Okay. Yeah, I'll jump in. I think maybe just to give a bit of sort of background on myself, I did a bachelor's in psychology and a master's in occupational therapy, and finished up with that in 2012. So I've been working for almost 10 years now. That entire time I've worked in mental health and addictions. That's sort of my passion. That's the area that sort of drew me in right at the beginning. But occupational therapy is super, super broad. So if any of you have any experience with occupational therapy or know any occupational therapists, our roles can be super diverse, working with, geriatric populations, pediatrics, developmental disability, recovery from brain injury. There's a pretty wide range. Typically the OT role is just looking at that interaction between the individual, their environment, and their meaningful occupations, which when we talk about occupation, we're not just talking about work, we're talking about, yes, productivity, but also leisure and self-care. So that's kind of the OT sort of overarching philosophy. We're very focused on client goals and being client-centered. So looking at what's important to people, what they value, and supporting them to be able to re-engage in those things despite whatever barriers they may have. So for me, my background's been not quite as broad as all of what I mentioned before. My first job was in a residential treatment center for mental health and addiction. I've worked with a couple different early psychosis intervention teams. So working with young people who've had a first episode of psychosis and are kind of trying to figure out, what's going on and how to live their lives with this new sort of chronic illness. I've worked in the downtown east side in a community-based mental health team. And my current role, like Joel said, is with the Mental Wellness Day program here, which is a group-based program primarily for outpatients with a broad range of serious and persistent mental illnesses. So usually that would mean, schizophrenia, bipolar disorder, depression, quite severe anxiety disorders. So a bit of a broad range. And my sort of primary focus here is working again with younger people with a first episode of psychosis. I've got a few other clients on my caseload, but that's kind of my main area. Also, typically my colleague Daryl usually does these presentations. So this is my first time doing this one, and I've got a lot of info that I've crammed into our time together. So if I'm going too fast or skipping over stuff that you want more information on, just feel free to unmute yourself and pipe up, because I think that'll be nice too if it's a bit more interactive. I will just share briefly what our sort of group calendar looks like here, just so you can see the range of programs that we offer. We've got a bunch of occupational therapists working here. That's sort of the most common clinical background that people have, but we do also have 2 registered psychiatric
Nadine,
nurses.
can you zoom into that?
Oh, yeah, sure. Is it small for you guys? Let me.
Yeah, it's super small.
Oh, okay. Okay, is that better?
So much better. Thank you.
Okay, great.
Yes,
yeah, sorry
awesome.
about that. Yeah, and we have recreation therapist as well, and 1 social worker. So it's pretty interdisciplinary. No doctors on our teams, but we do connect regularly with the psychiatrists that are working with our clients. And we've got kind of a mix of what we would call activation groups, like ones where people are just getting out of the house, being around other people, doing things, if that's something that they've been struggling with. Like we've got the VicAM as a board game and card game group, which is really fun. We've got walking and strength training groups. Of course, we offer yoga with the help of Ajna, which is really amazing for us to have access to that resource, and for our clients to be able to access yoga where they may not be able to otherwise, or to do so in a supportive environment if they may not feel comfortable or be able to participate in the community yet. We've got mindfulness and relaxation groups, West African drumming, and then a lot of sort of more what we'd call like psychoeducation groups, like learning about your illness and your symptoms and how to manage these and reduce the risk of relapse in the future. And a couple of CBT groups. So cognitive behavioral therapy, we've got 1 focused on depression and 1 that I run, which is focused on managing symptoms of psychosis. So right now it's kind of a mix of virtual and in-person groups. It has been for the past 2 years. Previously it was all in person. So there's of course pros and cons to the virtual aspect. It does make it a lot more accessible for some folks, which is really, really nice. And I think we will keep some virtual groups going forward. But of course, then you don't get that aspect of getting out of your house and being around other people in person, which is also really important for people's mental health recovery. So yeah, it gives you a little bit of a sense of what we offer. Any questions or things that you'd be curious to know about our program or just sort of the public mental health system in general before we kind of start moving into the material? Oh, yeah, Cheryl?
Hi, Nadine. I'm in Richmond.
Oh, great.
And so I actually have, I said on day one of our course, I have a meeting actually next week with an occupational health therapist. She
Oh, great.
happens to be, and she's the manager of the outpatient program with mental health services in Richmond.
Oh,
So to
nice.
look at reintroducing therapeutic yoga into their program. There was a
Oh, amazing.
psychiatrist who was also Indian, and he brought his Eastern cultural knowledge into his psychiatric practice with the patients, but he's
Oh, great.
retired, so they're missing that. So I'm just
Okay.
curious, yeah, so I'm just curious if through Island Health, which is where you are, right? Is there other sort of like programs in the various health authorities in BC? And if possible, would it be appropriate for you to let us know sort of like who might be the manager of those programs or who sort of oversees those outpatient programs?
Right. Well, I have, I mean, we have our coordinator here in our program who
Right.
is, connected, we've had that connection with Jules and Ajna Yoga for the last 10 or 12 years. And she also supervises the inpatient programs as well, where we also have volunteers from Ajna supporting clients in the inpatient unit. But I can't say I know too much about sort of outside of our specific program. We run outpatient programs for pretty much the whole lower sort of South Island, like up to Sydney and out to Souk. So we're kind of the main resource, I guess, where people would access yoga through a mental health program here. There is a treatment center that's only opened up in the last couple of years on the peninsula here, and I'm just blanking on, is it Ravens View, I think. I don't know what they offer in terms of yoga offerings, but I'm sure they do have some. But again, they're sort of separate from Island Health, so I'm not too sure. Beyond that, who's.
So would it be fair to say that within each health authority, then there's the regions within the health authority, which is huge
Right.
usually, and
yes.
so then it's really sort of localized programs. Is that a fair
I would think
assessment?
so. I think that would be
okay.
Yeah, if people are interested in having those discussions or offering support with instruction with yoga or program development kind of stuff, then I think it would be more at the lower level to approach first. Yeah, that would be my
Great,
best guess. Yeah, you're welcome.
And Cheryl, maybe just to jump in there as well, I know for us when we started working with the hospital, there was sort of two approaches. So one was there's a volunteer coordinator that's responsible for whatever region, and all of the volunteers need to go first through training, and then they have that external supervision, which is through us. And then the other would be the folks that are actually supervising the programs, either inpatient or outpatient. So maybe two different avenues for you to look at. And that goes for, I know some of you are in different parts of the country and some of you are in the States as well. So all different structures going on. Kate looked like she had a question in the chat, and then I see Russ's hand up.
So I can see Kate was asking, is this a standard program for Island Health or is it unique to our hospital? It is, kind of unique to our hospital. I'm sure there are probably similar groups and supports offered in different areas of Island Health, although I'm not familiar with them. I've only worked here in Victoria and then also on the Lower Mainland in Vancouver and Burnaby. So I'm not familiar with other areas, but I imagine there are sort of similar types of group-based programs or outpatient programs. And yes, thank you, Homewood Ravensview. That's the one I was trying to remember the name of. Great, and they do offer yoga and other activities. That's great, thank you. I wasn't too familiar with them. And then was there a question from someone else, Russ?
Hi, Nadine. I'm just curious about the West African drumming you were mentioning. Can you give me some more information about that, please?
Sure. Yeah, that's another really amazing partnership that we have with Fellow is actually a drumming instructor at the university here at UVic. So he has done a ton of training in various regions of Africa and knows a lot of sort of the history behind different rhythms that he's bringing and sharing with clients. It's a really great group, I find, for clients who it's kind of a grounding activity. Like drumming, it's so much focusing your attention on something. Like for clients, for example, who are dealing with auditory hallucinations or intrusive thoughts, it can be a really good way to just get a little moment's peace while you're focusing on what you're doing, and you're also part of a larger whole. Like there'll be maybe 3 different rhythms going on at the same time, and you're building your focus and concentration. So there's like that cognitive piece as well. Feeling part of a group, learning a skill and seeing your skills improve. Yeah, it's a really neat group. I used to co-facilitate, not that I have any kind of a drumming background, but there to provide the clinical support with him. So I had the opportunity to observe for a couple of years there as well. Yeah, we really benefit a lot from getting these partnerships because, we all have our kind of clinical background, but we don't necessarily have the specialized skills in the things that, clients can benefit from all the time. So like yoga or drumming, really nice to have those supports. Yeah, anything else before? Oh, you're welcome. Yeah. Julesy, do you have anything else to share just in terms of the yoga or volunteering process or anything else that you wanted to say about that?
Yeah, so we started it really in conjunction with the group teaching practicums, which you all do, either as part of the 300-hour program, your 1 6-week program, or as part of the 800-hour program, the Yoga Therapist Diploma program, your 63 hours of group teaching. And that's the one that really took off with VIHA, with Island Health, because they ask for, of course, like a minimum number of months to commit to, because they go through this training process, and then people actually got really hooked. One of our students a few years ago actually made, which you'll see if when you take the yoga therapy immersion, a short form intake form that was like non-intrusive. So usually when we do intakes, we ask so much information from our clients, but in a clinical setting, when folks are potentially inpatient in a hospital or outpatient, it's not appropriate to be asking them so much information. So one of our students developed the short form that we now use in all of the settings like that. So we have volunteers who work in the inpatient ward, and there's always somebody there, like Nadine was saying there, that does clinical supervision. So either a nurse or an occupational therapist or a social worker, so that they're there with the yoga therapist in training, just to support clients, the patients there, if anything comes up, so that the person teaching yoga, practicing yoga therapy, can focus on that. And then the other person is there if need be to step in. We've also had students do placements in all sorts of different settings. So not just with VIHA. And actually I was talking with Izzy right before. Izzy, would you mind sharing a little bit what you've been doing?
Yeah, so about a year ago, Michelle contacted me with an opening that was happening with Portland Hotel Society, or PHS. They have a specific program at their Arbutus location that's called the Downtown Recovery Program. And it's quite inspiring to see how they have it organized, because the schedule is similar, where there's a lot of different holistic programs available to folks. Like every day there's probably 2 to 4 different types of programming going on. So I love to see that, because I've worked with the population for a long time and haven't ever seen access in this way. Typically it's one-on-one, because there's usually about 9 people living in the program, and depending on where they're at, because folks are often like active in addictions, the recovery aspect is like very harm reduction focused, so it's their version of recovery. So I really love being able to do the one-on-ones, because you're able to apply like the learning and the teaching to one individual person, which is nice, and try and hold a space for them. I find folks there mostly like are drawn to doing yoga nidra most often, which is nice because I love that. And they have lots of nice props too. They have tons of bolsters and blocks, and so I feel like well set up. We are in a room where there are people coming and going from, so I try and let that be part of just like people might come and go, and that's okay. I do wish like it'd be great to see more resources where we could have a room where people could have like that, safe space where they don't have to worry about outside influences or people looking at them. But yeah, really grateful for the opportunity. It is a paid gig, which is important for me because I gotta pay the bills. And yeah, there's Grace that was in the program, or not the program, the business.
Yeah, she's in the program as well, just not
She's in the
this
program.
module. Yeah.
And Becca also do some teaching there as well. Yeah. Is there anything else you wanted me to say about that?
No, that's just perfect to see.
Okay.
Yeah. Thank you for providing the context for it. And also, I love what you were saying around how you've developed this network with other students. Because I know that, for example, you're subbing for each other, which is important for consistency for the clients to have the classes going. So lots of different opportunities out there. When things come in, we send them right out to you folks. For those of you who aren't local, I'd encourage you to develop a network around you as well. Sorry, Izzy, go ahead, sweetie.
If anyone, I do actually need a sub because Grace and Becca aren't available. So PM me if you have experience working with folks in addictions and kind of hard to house populations. I'm looking for a sub, so maybe PM
Excellent. Thanks, Izzy. Also, you can put that on the Facebook group as well. Awesome. Thank you. Oh, back to you, Nadine. Thanks.
Sure. Yeah. So just in terms of what we'll be talking about today, my primary focus is on psychosis. I think that's kind of, you've got other people talking about, depression and anxiety. Also, psychosis is my, main thing that I'm working with here. We'll talk a little bit about, what psychosis is, what that might look like, what it might, be like as an experience for a person who's going through it. I do quite a bit of cognitive behavioral therapy here, and I'm going to talk a little bit about what that is, and also a little bit of fear and how it impacts the brain, whether that's anxiety or fear related to delusions or whatever. We all experience fear in our lives that can impact our thinking. A little bit about neuroplasticity. And then my last piece is just about lifestyle factors that are important in mental health recovery or just our wellness in general. So primarily, I'm just going to chat about substance use, stress, and exercise. Obviously, there's more than that to talk about, but trying to keep it somewhat concise. I'm not sure if I'll manage that. And this is all sort of from my perspective as a clinician in public mental health. But I hope that some of what we're talking about here will be helpful as you move forward into your yoga teaching in the community, or maybe in a setting where it's working with a population who might be going through some of this stuff. So please, as I said, just please ask questions. I may not notice as your chat comes up if I'm sharing my screen. I can't quite recall if that pops up for me. So unmute yourself, or if I miss something, Jules, if you can just let me know in the chat. I'm happy to have people asking questions and participating, and yeah, hopefully we'll be able to cover it all without it being too too much information. I'll just share my screen here with my first little PowerPoint. Okay, so can you guys all see that okay? Yeah, okay, I see a thumbs up. All right, so we'll talk a bit about psychosis. And I know Jules has sent out a link for a short documentary that I think most of you guys will have seen, that Living with Psychosis documentary from New Zealand. I just find it's like a really good overview of who might get psychosis and what that might be like and what recovery is like for people, a little bit about how much the stigma can really impact people in their recovery. I think that's one of the most difficult things to deal with for people who are dealing with these illnesses. And I like it because it gives just a more realistic picture of, what psychosis is like and what recovery is like. Because I think the picture we get from the news or from the media is not necessarily a super hopeful one. And that can be pretty heavy for some of the clients who are coming through our program and dealing with a new diagnosis that just feels like a life sentence, right? So you guys will already know, if you've seen that documentary, more about psychosis than most people in the general population. Unfortunately, it's not a very well understood type of symptom. So we'll chat a bit about it today, talk a little bit about treatment, factors that can influence the recovery trajectory for people, and a little bit of detail about common psychotic disorders and their presentation. That'll be our first bit before the break. Just realizing, Jules, I might just grab my phone so I have a clock, because I realize when I share my screen, I can actually see what time it is.
Yeah, absolutely.
Okay, so I guess one of the main things to start with is just that psychosis is not in and of itself a diagnosis or an illness, it's a symptom. So it's a symptom that interferes with your brain's ability to know what's real and what's not real. That's the very super simple explanation. And when someone is experiencing this, it's called a psychotic episode. And the first time this happens for someone, it obviously can be really frightening and confusing and distressing. And people will have no idea what's going on, or just maybe no insight into what's happening for them. It's really difficult to think clearly when you're in this mental state. Thinking can be extremely disorganized. Your judgment may be quite poor. You might be feeling confused. Often people are fearful because they're dealing with paranoid thoughts or beliefs, or experiencing auditory hallucinations, saying really negative stuff, or making threats to them. And that can all feel very real, especially when they've never had it before. And so there's no kind of, baseline experience to refer back to. People misperceive what's going on, with other people in their environment, or their senses are giving them the wrong signals with hallucinations. Focus is really difficult. And often people just get this massive sensory overload. So it can be really, really difficult to filter out irrelevant information and focus on the things that you're wanting to focus on. So I think of, you can kind of compare psychosis to a fever, in that like a fever can come up with all kinds of different illnesses. There can be all kinds of reasons someone might spike a fever, and you kind of need to figure out, okay, well, why is this person having a fever? And it's the same thing with psychosis. There's a huge range of diagnoses or conditions that can cause it, not limited to the list on the screen here. Bipolar disorder, schizophrenia. I mean, bipolar disorder, you may not always have psychosis. It's about maybe half of the people who have bipolar disorder will have some experience with psychosis. Schizophrenia and schizoaffective disorder, schizophreniform disorder, those always do involve psychosis. Delusional disorder does as well. People may experience substance-induced psychosis. Major depression, in some cases, people can have psychosis as well. That's something I didn't even know until I started working in this area. Or people may experience a brief psychotic disorder. Of course, there's all other kinds of reasons someone may experience psychosis as kind of like a transient thing. I have a friend who had malaria when she was traveling and had visual hallucinations, or, if you're in alcohol withdrawal, you may have some hallucinatory experiences. So not limited to this list, but those are kind of some of the main diagnoses. And I think it's also important to remember that nobody actually is totally immune from psychosis. It occurs in all sorts of people. Doesn't matter, male or female, where you live in the world, how much money you have, all these things, it really, it doesn't matter. Almost anyone could develop psychosis if they were under enough stress. So maybe going through a long period of no sleep, or overusing certain types of drugs, such as amphetamines, for an extended period of time. But of course, some people have greater vulnerability to psychosis than others. And that's just due to a few different factors, a lot of it genetic, but also environmental factors. So it can be hard to say for sure and pinpoint the exact thing that caused a first episode of psychosis for someone, it's typically a mix of biological factors that are making the person more vulnerable to begin with, and then maybe some environmental stressors, whether that's substance use or stressful events in their life, and some kind of an imbalance with their neurotransmitters, so the chemicals in your brain kind of getting out of whack. So typically that's involving dopamine and serotonin that can be a factor in the development of psychosis. This is, I'm not much of a graphic designer. This is my attempt to illustrate something on Microsoft Paint, but this is kind of a way I explain it to clients. So you can imagine like a glass of water, and the pre-existing vulnerability, which typically would be some genetic vulnerability, maybe a family history of psychosis or other major mental illness, maybe some kind of gene mutation that just happened in utero or whatever. This is sort of some water in the cup already, and you won't likely know, how much water is in that cup to begin with. And then we add in all the environmental stressors, which are kind of like, if you can imagine pouring more water in the cup, whether that's, extreme lack of sleep or substance use, starting a new job or a new school program that's intense and stressful, feeling isolated, not having appropriate social support, immigration to a new country, relationship conflict, all of these things are stressors for our brain and our body, and those things can contribute to that elevated risk. So if you get enough of that, or if you have a lot of pre-existing vulnerability, the cup kind of overflows, at which point that person experiences psychosis. So just a bit of an illustration there. When people are experiencing psychosis, that typically involves some combination of delusions, hallucinations, and disorganized thinking or disorganized behavior. So we'll be talking in a lot more detail about those. A delusion is when someone has a belief that's sort of, to other people strange or unrealistic, but it's really firmly held, even if there's evidence shown to that person of the contrary. It's really difficult to shake that belief in someone. And they're truly convinced of the belief, even with the most logical argument. And when a family member develops psychosis, their family is just going to be pulling their hair out trying to explain to this person, like, this is not what's happening. But of course, to them, it's feeling very, very real. Common types of delusions would be believing you're being followed or threatened by someone, someone's monitoring you in some way, maybe thinking you have special abilities or powers, believing there's a hidden message that's intended just for you in songs or in advertisements that you see, looking at different license plates and seeing the combination of letters and numbers and thinking that there's a message for you in that. Sometimes people might think that others can read their mind or hear their thoughts, or that they can hear other people's thoughts. But really there's like an infinite number of possible delusions that someone might have. Hallucinations, on the other hand, are more of a sensory error, a misperception coming from the brain, where people can hear, see, smell, taste, or feel something that isn't there. So again, these experiences can be just as real as my voice talking to you right now. That could be someone's experience of an auditory hallucination. So of course, it can be really, really difficult for that person to understand what's real and what's not real. The same areas of their brain are active as if they were hearing someone talking to them, or if they were feeling something, on their arm. So it can be really disturbing and scary, and also just distracting experience to have these sort of sensory experiences going on without an external stimulus. And the most common type of hallucination is hearing voices or maybe other sounds, so auditory hallucinations. So the other type of sort of cluster of symptoms I mentioned was disorganized speech, thoughts, or behavior. If you're speaking to someone who is experiencing a psychotic episode or maybe chronic symptoms of psychosis, it might be really hard to follow their train of thought when they're talking to you. They might be kind of jumping around from topic to topic, and you think you've got it pinned down and then it moves on to something else. It can be hard for them to concentrate and follow a conversation. Their thoughts might feel really sped up, or else really slowed down, or just jumbled up and disconnected. And in terms of their daily function, they might start to have difficulty with maybe doing their self-care tasks, like taking care of their apartment or their home, cooking for themselves. managing duties at their work or at school, or they might behave in a way that seems really socially inappropriate, just because they're not able to process information in an accurate way. Just briefly about neurotransmitters, so those chemicals that our brain uses to function and relay messages in our brains. Typically, psychosis is associated with too much dopamine in a part of the brain. And it seems also serotonin might be involved. But what's tricky is these neurotransmitters are involved in a ton of other functions as well. So when we're treating psychosis using medication, which is a really important part of the treatment, unfortunately, we don't have a way to target just the part of the brain that's causing the psychosis. And that's where sometimes people experience difficulties with side effects, because though the dopamine level is being lowered in the whole brain, and dopamine also has to do with memory and learning and movement and all these different things that it's used for in our brain. So sometimes people might have some difficulties with that. Hopefully in the future we'll have a better way to do it, but that's where we're at right now. One thing that's just super important with treating psychosis is making sure people are accessing support and treatment as early as possible. People who get treatment earlier tend to have much better outcomes in terms of their function and their recovery than people who have a longer duration of untreated psychosis. It seems as though psychosis has sort of a toxic effect on the brain. So delaying treatment can actually mean that people recover less well in the long term than if they got that treatment sooner. That's why we have an early psychosis intervention team here, and in most areas of the province. Some smaller communities don't have that specialized team, but these teams have extra resources to make sure that the case managers have smaller caseloads and can spend more time with people, that they're able to see their doctor more often. There's more support for the families. So that's just a really important thing that, fortunately, there's more funding for those programs now, and more of those programs available than there was 10 or 20 years ago. Also, multiple episodes of psychosis tend to lead to worse outcomes. The more episodes of psychosis a person has, the more challenging it can be to recover from that. It's kind of like having multiple head injuries in a sense. So we really, really work hard to support people to reduce their risk of relapse when they come into our program and into other mental health programs.
Nadine, can I ask a question around age?
Oh, of course,
psychosis, in terms of how it might look for our youth, say folks who are in their late teens, early 20s?
Yeah, that's a great question. Yeah, I mean, for males, it tends to be a bit earlier than for females. So something relating to sort of hormone levels seems to have an influence. So typically for males, it would be kind of around age 15 to 24 or so. And then for females, more early 20s to early 30s, or mid 20s to early 30s. But of course, it can develop, in different situations. I mean, the hormonal piece is really interesting. Like some people will have a postpartum psychosis after giving birth, or maybe experience some symptoms with menopause. So there's something there with the hormonal piece as well. But yeah, typically it's, happening, in mid to late teens, early to late 20s, later for women than for men. And some of that has to do with just how our brains develop. I talk a little bit about it later, but yeah, your brain's developing until around age 25. And there's something going on called synaptic pruning. So your brain's getting more efficient, things are getting pruned away. But in that process, sometimes it can unveil that sort of pre-existing vulnerability.
Thank you.
Yeah. So early treatment, super important in those first 2 to 3 years. When people get treatment early, it's kind of like this illustrated by this blue line. So people tend to come back to somewhere close to their previous level of function, or maybe just as well as they did before. If the treatment is delayed, it tends to be a worse outcome the longer it's delayed. And this is general. I mean, there are some people who do super well even though their treatment was delayed, and people who really struggle even though they got the best treatment right away. So that's just sort of a generalization. When I'm talking about treatment, typically that would involve medication, antipsychotic medication, to support people in managing their delusions and hallucinations, and to sort of correct that balance with their neurotransmitters. Another really useful tool is CBT, which I've mentioned. to help manage any residual symptoms. For some folks, maybe it just takes a while for their medication to help resolve the hallucinations and delusions. And for some people, unfortunately, the medication doesn't fully resolve those symptoms. And then it's a matter of learning to cope with and live with those symptoms. So learning skills to manage those. We also do provide psychoeducation, so learning about your illness and how to manage it, support with developing a healthy lifestyle. And as an OT, a big piece of my job is helping people re-engage with community-based activities. So going back to school or work or volunteering or meaningful leisure activities that they enjoy. So all that meaningful occupation piece. I think I'm going to skip through the medication piece a little bit because we've talked about it already. But as active psychosis, obviously it can really get in the way of you living your life. It gets in the way of your ability to function, to either keep your job or obtain one if you need one, attending school, managing your responsibilities, parenting, maintaining your relationships, your romantic relationship or your friendships as well. Just making good decisions and staying safe. All of these things can be impacted by psychosis. So another thing to think about is just, the disruption of that event in your life. The symptoms don't just resolve and then you just go back to normal. It's, I think just in terms of your sense of self and your identity, it can be really tough to overcome that piece. I think, psychosis is one of the most, or maybe the most stigmatized mental health issue that people can have, right? A lot of people think it's really scary. When I talk to people, in the community about, what I do for work and who I work with, I get some, I think, kind of like weird reactions about like, well, like that must be really like frightening. And it's not at all. Like, I love my job. I love my clients. And occasionally, if someone's really unwell, yes, maybe there's some, higher risk situations to manage. If someone's like very paranoid and, having a hard time interpreting reality, then sure, there can be some risk there, but that's typically not the case, especially as an outpatient program. But, for someone who's maybe held that belief themselves, and then all of a sudden they've got this label on them, it can be really hard to move through that and, have a kind of healthy view of yourself and what you're able to do and feeling comfortable disclosing to people close to you about what you've been through. So reducing that risk of relapse is super important, not just for brain health and recovery, but also to minimize the number of times someone's life is going through that disruption with their activities and their relationships and their, job and education. Because psychosis is a symptom in so many different types of illnesses, there's obviously a huge range of experiences that people can have in their recovery, even for the same diagnosis. Like, for example, with two people with schizophrenia, how their symptoms present and how they respond to medication and how much it impacts their daily function can be super variable. So it's hard to say, for any one person, this is what your recovery is going to look like, because we just don't know. Also, the recovery process can be really, a lot of ups and downs. It really requires people to challenge themselves and work towards their goals in a gradual fashion. Sometimes people struggle to just get started doing the things that would support their recovery, or at the other end of the spectrum, they're trying to jump into full-time work 2 weeks after they've left the hospital, and it's just way too much. And it's kind of supporting people to find the right pace to get back to their activities. That's a lot of what our program is aiming to do, is kind of be that bridge, help people engage in structured activity and figure out what's working for them, what's manageable for them at this stage in their recovery in terms of being able to sit and focus on, say, like an educational group before they're going back to classes at university. And it's really important in this sort of early phase just to do everything you can to support the brain in this sort of early vulnerable stage of recovery.
Nadine, I just saw something in the chat from Russ that says, sounds like psychosis and dementia have many similar symptoms.
I mean, it could be, yeah. Yeah, I mean, there's definitely similarities and differences. I mean, dementia tends to be more progressive, whereas with psychosis, people can, have this period of really acute symptoms and then have them, completely resolve, or in some cases, just almost completely resolve. And so there is that big difference, I think, in terms of the trajectory, anyhow.
Mm-hmm. Thank you.
Mm-hmm. And when I'm talking about recovery in terms of mental health, we're not necessarily talking about a complete absence of mental illness symptoms. So the Mental Health Commission of Canada defines recovery as living a satisfying, hopeful, and contributing life, even when a person may be experiencing ongoing symptoms of mental health problems or illness. I mean, it could be kind of, considering what I think was it Izzy who was talking about addiction before. I mean, recovery is not going to mean the same thing from person to person. So we're just wanting to support people to live the best life that they are wanting to live and doing the things that they want to do and being able to engage in the things that they value. So it may look different from person to person.